Good morning, everyone. I'm Ronan McMullan, and I'm a medical microbiologist by background, and today I'm here as Clinical Director of Training and Assessment at the college. And my topic for this morning is about focusing on the issues that arise when making adjustments to the workplace for a doctor in a training program who has to complete the outcomes of a higher specialty curriculum. And so I also have a little second topic to deal with at the end, just for a couple of minutes, which I'm considering a bonus track. Now, has that moved on to my second slide?
Yes.
Great, thank you. So the GMC has some guidance on this topic, and there's a document named Welcomed and Valued that you'll be able to find and have a look at. And this document is guidance from the GMC, which is a little bit different from the usual documentations that we see from the GMC, which tend to be standards. And standards, of course, are not optional, but this guidance document is really setting out what good practice should look like, and it encourages us to find ways to enable a diverse range of doctors to work in the NHS on the basis that a diverse workforce is a good way to serve a diverse population. The GMC standards require organisations responsible for training doctors to support disabled learners by making reasonable adjustments. So they set down in their standards what the obligations are, but they're very clear in this guidance document that the GMC itself can't define what a reasonable adjustment might be, specifically what adjustment is reasonable. So this is something that has to be worked out by employers, and I appreciate that this can be a challenge, and it can bring additional complexity when we have to think about what adjustments are reasonable and what adjustments allow us to continue to deliver training appropriately. So equality legislation imposes an obligation on employers to appropriately take care of employees with disability. And effectively, this is all about adjusting the way that things are done to remove barriers for disabled people. In broad principle, healthcare employers, and particularly the NHS, understands this obligation. Healthcare employers have an occupational health resource to rely on for help whenever approaching this. And I think it's fair to say that as a really large organisation and as a very big employer, the NHS is experienced in the business of making reasonable adjustments. So the college is not setting about telling employers how to do reasonable adjustments. Our position here is to try to offer some advice when we think about reasonable adjustments in the training context, because there are additional factors to consider when adjusting the workforce for the workplace for a doctor in training. The first thing that I think we have to keep in mind is that achieving curriculum outcomes that we frame in our curricula as capabilities in practice, or SIPs, is an absolute requirement. So achieving the outcomes of a curriculum is not something that's non-negotiable, whether doctors in training have a disability or not. And you know, this first paragraph is taken directly from the GMC document, when they make clear that it's a patient safety concern to ensure that doctors in training meet the competences set out for different stages of training in their curricula. So this is set in stone, and we have to work around this when we're considering reasonable adjustments. There's no doubt that the workplace environment and the process of training should be adjusted for doctors with disability, but the curriculum outcomes cannot be. And although the ARCP process is not a place where it's appropriate to consider how to make adjustments or to choose adjustments or in any way to judge their reasonableness, it is a place where we have to look at how a trainee is progressing and decide whether they're achieving their learning outcomes, and whether the adjustments that have been made or can be made are able to support the doctor to meet the competence standards required in the curriculum. So there is a slightly more complicated interplay between training requirements and employer requirements when we think about a doctor in a training program who has learning outcomes to make. So the college has a guidance document on making reasonable adjustments to training, and you'll find it in the training section of the website. So if you go here to training, you can see down near the bottom of the training page, there's a bit called Guidance and Forms for Medical Trainees. So in there, if you click through that, you get a page that looks like this, and down at the bottom of that page, there is a link to the document, which is about principles for reasonable adjustments to GMC approved training programs. And really, what this does is it sets out some fairly obvious principles to consider, and many of these you'll be familiar with. The first is responsibilities, because clearly each training organisation has its own particular responsibilities in this area. The college, for example, has an obligation to ensure that our curricula do not disadvantage any particular groups of doctors in training. And an example of those groups might be doctors with disabilities, but it extends to lots of different groups of doctors. There's also a responsibility on the part of doctors in training themselves, because we need people to engage early and constructively if they think that they need reasonable adjustments. And there's a kind of dialogue required between the doctor in training, the employer, and the trainer to consider what reasonable adjustments are required, what are deliverable, and how that impacts on training, and particularly how the training process can be adjusted to ensure that even if someone can't do all of the usual tasks that would amount to a learning encounter or enable them to be assessed in a particular capability, there has to be some adjustment to take account of other ways to allow them to demonstrate that they can do certain tasks and produce assessments to evidence that. Postgraduate deans and employers clearly have a very big role, and you'll all be much more directly involved with those groups to consider whether adjustments are required and what adjustments can be made. And as I say, there's a need to consider tasks which we consider to be of importance in training. We need to consider what alternative tasks would allow the doctor in training to develop the skills they need and demonstrate having developed the skills they need. And I think this is something that has to be worked out very much on a case-by-case basis by addressing the barriers that any particular individual doctor faces in the workplace. And I think that, in pathology specialties, we're likely to encounter those barriers in the laboratory or in the mortuary, where we might need to break down the tasks into some more individual components so that they're much more manageable for the trainee. So, what support can RCPath add to enable inclusion of doctors with disability who require adjustments to training? Well, the first thing that we aim to be able to do is to offer informal advice prior to recruitment, because doctors who identify themselves as having some difficulty in the workplace may be concerned about their suitability for various specialties. And so we aim to be able to offer them some informal advice prior to being recruited to a programme. And similarly, we aim to offer informal advice to recruitment teams who are in the process of appointing doctors who may have difficulties in the workplace. And really, I think we have to appreciate that this is a fairly limited bit of informal advice, because at that stage we may not have access to all of the information that you would normally have access to with, for example, occupational health assessment. So we may not have all of the knowledge that's needed. But in terms of a kind of a casual chat about what barriers a doctor with disability might face and how they might be overcome, and whether we've encountered this kind of thing before, and maybe seek advice through our college specialty training committee, where colleagues have overcome barriers like this before. So we hope to provide that kind of informal advice before entry to a training programme. And naturally, when trainees have been recruited to a programme, training programme directors may well be grappling with the issues that I've mentioned, where a trainee can't complete all of the tasks that are considered to be essential for completing training. And so we appreciate that actually, trainers, employers, deaneries are already very good at this. They deal with it all the time, and in fact, mostly won't need much input from the college. But when adjustments to training are being considered and a situation seems particularly complicated, or when there's concern about how to allow a doctor to demonstrate that they are able to complete a curriculum outcome, we are very happy again through our specialty training committee and also the reasonable adjustments advisory panel to provide some advice when we can about that. And really the focus is to ensure that assessment requirements can be met and the training requirements can be met. So that was a run through of the perspective of the college and the perspective of training whenever reasonable adjustments need to be made for doctors in a training program. There's just that extra layer of complexity in terms of their curriculum outcomes. So I was now going to briefly move on for a couple of minutes just to introduce something else to you. Over the past several months, we've been developing in the college some guidance that addresses the topic of bringing forward CCT dates. And what I'd really like to do is just put that on your radar this morning and signpost you to some guidance, let you know where it is and give you the chance to think about it and get to know it before you might wish to implement it. And really this is all based on the fairly recent shift to capability-based curricula, which de-emphasizes the very strict counting of time that was required whenever trainees were going through programs. So the emphasis is now much more on capability that's been achieved rather than time spent. And logically, as well as taking longer than the indicative time for some trainees, there are circumstances in which training time may be shortened. These circumstances are already alluded to in the Gold Guide, but the operationalizing of that is very much left with deaneries at present. So we've developed some guidance documents to help within the pathology specialties to navigate through how that might be achieved. And the first is about doctors who are able to progress through a training program because of exceptionality in a shorter period of time. We've developed some new guidance also on recognizing capabilities that were gained before entering a training program, because careers have become a little less streamlined these days and many doctors will enter a training program having already acquired some of the capabilities that they need to gain during the program. And this also has some implications for recognizing capabilities gained while out of training programs, because we've, I think, moved from the position whereby we could prospectively approve time counted while out of program and just accept that that was going to be how it was and not look at it again after trainees came back, to now thinking about, well, actually, every year a trainee is reviewed at RCP and we consider whether they've met the learning outcomes that were expected. So it makes sense to look at a trainee and review their performance after returning from a period out of program and ask, have they met the learning outcomes that had been expected for the period that they were out of the program. So just to give you a very broad flavour of the pathways for recognising prior training and accelerating trainees through programs because of exceptional progression. These both require a gap analysis to be undertaken, and that's where the educational supervisor will review the trainees' evidence and document what capabilities they had achieved at that point in time. And then based on the gap between those capabilities and the capabilities required at the end of training, estimate the remaining training time that that doctor needs in a program. So this is very much like an educational supervisor's structured report that you'll be familiar with, but with the added layer of considering what additional training time is likely to be needed. For trainees who come to a program with prior capabilities that we'd like to recognize, the decision to recognize those previously acquired capabilities should be taken at the first ARCP, so at the end of their first year, to agree a CCT date. At the other end of the spectrum, those who are considered to be exceptional and are able to be accelerated through the programme can be accelerated at any time up until the penultimate ARCP. So they should have at least a year left of their indicative training time by the time they're being accelerated. And I think it's fair to say that in the pathology specialties with the RCPath exams, it would be difficult to accelerate trainees confidently who have not already passed the RCPath, but that's not by any means an absolute requirement. And just fleshing out the out-of-programme issues, well, for anything that isn't out-of-programme training or out-of-programme research, there's no current provision in the Gold Guide for that to be recognised towards training time. So there's no change to that at present. However, to allow some kind of retrospective review of prospectively approved out-of-programme periods, we're suggesting a slight change in the process. So we need to continue to have prospective approval before a doctor leaves a training programme for an out-of-programme period. And that's at both deanery level and at college level. When that approval is granted, we'll give a prospective indicative time that we expect will be counted towards training during their out-of-programme period. When they return to programme after that period, there then needs to be a retrospective evaluation of the capabilities that they've achieved. In other words, how they've progressed in their SIPs. At this point, you might wish to look at the gap analysis form and use that as a way to document those, but it's not essential. If it's considered too onerous for this process, you're not obliged to use it. And then at the doctor's first ARCP after returning to programme, the CCT date is reviewed and confirmed based on the progression that they've demonstrated during their period out of programme. The guidance for this is in the same place as before. It's in the guidance and forms for medical trainees, which you find in the training section of the website. And in there's guidance and there's the gap analysis forms for each of our specialties. So wrapping up, thinking about reasonable adjustments to training, evaluating the need for adjustments and deciding what is reasonable and what is deliverable continues to be, as it always has been, an employer responsibility. It's worth remembering that adjustments to the work environment and training tasks can and must be made, but curriculum outcomes cannot be adjusted for any doctor in the training programme. And while we at the college are very happy to give advice, this can be sought when uncertainty arises about how to meet and demonstrate learning outcomes, and that's very much the focus of what we hope we'll be able to support with. And finally, I've mentioned bringing forward CCT dates, which supports the move to capability-based curricula and less emphasis being placed on time spent in a training programme. And we have lots of guidance and lots of forms, and I know this is something that we're going to need to come back to make sure everyone's comfortable with, but today was really just about signposting that to you. So thank you.